everyone, and welcome to the first in a series of question and answer sessions hosted by the UAB Neuroinflammation, Pain, and Fatigue Lab. I hope you enjoyed the music. If you did, please tell me in the chat area. If you did not, you can also tell me in the chat area. We're looking for something that is easy on those of us with sound sensitivity and is pleasing and upbeat. My name is Tina Tidmore. I have had fibromyalgia for 9.5 years, but I've had CFS for 13 years. And in my times of function, I freelance as a communications specialist, and Younger Lab, which is the quick name for the Neuroinflammation, Pain, and Fatigue Lab, is one of my clients. And I live in Clay, Alabama, which is about 30 minutes outside of Birmingham, which is where the Younger Lab is. Birmingham is also where UAB is. That is the one that hired Dr. Younger to do this research and to open up the lab. UAB stands for the University of Alabama at Birmingham, and that is not to be confused with the University of Alabama that is located in Tuscaloosa. Two different cities, two different universities, and two different school colors. So I saw a roll tide in the comments, so that's nice, but that's for the other one. So we call it UAB here locally. I would like to introduce today's researcher from the Younger Lab. There he is, Dr. Jared Younger himself. He is the leader of the UAB's Younger Lab, or Neuroinflammation, Pain, and Fatigue Lab. Dr. Younger came to UAB in the summer of 2014, coming from Stanford. And he is most noted from a patient perspective for his research on low-dose naltrexone and showing how it is effective for fibromyalgia. For CFS patients in the spring of 2014, he made quite a buzz in a presentation before the ICFS ME conference, where he told about a hormone that goes up and down with CFS symptom severity up and down. So that is indicating a possible target for treatment, or a possible cause for the symptoms, or maybe something that is affected by what the cause of the symptoms are. Either way, it gave a good direction to go in. So, Dr. Jared Younger, you are a doctor, but do you see patients? We get that question a lot, don't we? At the UAB clinic, or I'm sorry, lab that you have. Are you that kind of a doctor? Is there anybody there that's providing clinical care or health care for patients?
All right, and you know the answer to that one. I am not that kind of doctor. I am a PhD researcher, and I am a clinical researcher. So I'm one of the PhD researchers that spend all of my time on people research. I don't do animal research. So it's close, but the difference is I only give medications in the context of a clinical trial. So I can't see patients one-on-one. That requires an MD to be able to do that. So we are trying to collect, because there is so much of a demand for clinicians that can deal with fibromyalgia and chronic fatigue syndrome. So we're trying to find all the people who can do that, but most of them are not trained up. So as our research grows, we will attract more and more MDs who want to be part of our research, and then they'll start doing clinical work in this area, and we'll try to get them trained and get them to see the right specialists to learn how they can treat it themselves. So no, we don't treat. We can try to do referrals, but the truth is that in most areas, there's not a lot of people to refer patients to, but we do what we can.
So the next question I've heard a lot of people ask is, why did you move from Stanford to UAB? Now here in Alabama, we know the big presence that UAB has, especially when it comes to medical research. But outside of Alabama, it's not commonly known. It may be, among other researchers, but what attracted you to UAB?
Yeah, it is. If you're a researcher, there are certain things you pay attention to that may not be obvious to everyone else. The main thing I look at is how much federal research dollars an institution brings in from the National Institutes of Health. And UAB is ranked 23rd out of all institutions in the nation. And that puts it in the top 25, which is where Stanford is, where Harvard is, where Yale is. And so it is the top 25 best funded institution in terms of the money it brings in from the NIH. So that is really, really impressive. And most of that is medical research. So the primary reason is UAB was clearly putting pain and fatigue and related disorders as a top priority. And even before they brought me in, they brought some other really excellent researchers, Rob Sorge, who does animal work, Burl Gooden, they brought in Zena Trost, all doing this kind of pain-related stuff. And so they're putting an enormous amount of resources into building a pain program, perhaps the best in the world. And that's going to allow me to do the fatigue work and the neuroinflammation work. So what I saw was a trajectory where things are just being built. And it's exciting to be in a place where I can be part of something that's growing very quickly, and I can be part and contribute to that. So they had a lot of resources to offer. They gave me a great position, a lot of resources to do the types of projects I needed to do. They had great equipment like the brain scans and a lot of really good colleagues. So it was, given the other institutions in the country, it really had an incredible combination of all those things I need to do my best work.
I believe there's a pain training center or something that was set up.
Yeah, it's a pain center of excellence, right?
okay.
Which means it's one of the very few institutes that have that designation, which means it really is superior in terms of training pain physicians. So
Right.
yeah, it's a good designation.
Yeah, so I can see where that would make UAB maybe possible for a good place for your research because it's in pain and
Right.
fatigue.
Right.
So how's your reception been since you've come? Have you, a lot of people, are not too big on this kind of research or medical care. How's it been from administrators and your peers?
It's all positive, almost overwhelmingly positive in terms of, I've been here now a year and a half, and I still have 4 to 5 meetings with new other faculty every single week because everyone wants to hear what I'm doing and be associated with it. So we almost have too many collaborators and opportunities, but that's a good problem to have. So the reception has just been perfect, really, in terms of getting what I need from administrators, people wanting me to talk in their departments and do grand rounds in their departments. So on the patient side and the participant side, it's been excellent. So we have hundreds of people who have signed up to do research at UAB through our lab. So just all good so far.
Well, I can tell you from my patient perspective, that is wonderful. That is so exciting. And that brings me to the next thing, and that is what I put out as an announcement from your lab. When you came in the summer of 2014, you had 4 people at the lab, and you said within a year you hoped that you would have 10. Well, within 7 months, in January of 2015, you had 11 working in your lab. And now, just a month or two ago, you gave me a new figure. So how many do you have working in your lab now?
I think it's 18. It's at least 18. There may be 19, but I think the number is 18. We have grown really fast, and the truth is that there are a lot of people that want to join the lab that we've had to say, we just don't have room now. So certainly what that lets me do in the idea of growing the lab is the more good people I have, the more good studies I can do at the same time. So we must have 12 ongoing studies going full steam right now. And so I get really good people, and that increases our capacity to do research. So we don't have to do one study at a time, which takes forever. We can run this all at one time, and then we can constantly churn out results. So that's what I've done. I've built 3 parts to the lab. So it's almost like we have 3 labs in one. We've got a neuroimaging lab, and they do brain scans and spinal cord scans. We'll probably talk about that. I've got a clinical trial unit, and we've got an immune testing and immune modulation, and those are led by Dr. Joanne Lynn. She's neuroimaging. Luke Parketney is immune modulation, and Emily Donovan and Kate Sides is kind of immune testing. So actually, Emily Sides would be Emily Donovan would be clinical trials. So we've got leaders in all those areas, and I supervise that and make sure that everything is going well, and we're doing a lot of good studies.
Now, when I saw the picture that you sent me to use in sharing this, I saw a lot of young faces. So I can tell you also as a patient, that's very exciting and encouraging, and makes us realize that the research is going to go on and that there's a future. And so what do you think is behind all this growth in your lab? What's making it happen so quickly?
Well, part of it is UAB itself has again, going back to that warm reception, they've featured our lab in their publications and kind of put us on the front cover and said, here's the really cool stuff that's happening. And I think the undergraduates and the graduate students, they see that, and then they want to be part of something that's making an impact and that's growing really fast. So that's been part of it. But I think people just really, when they see the papers, they just like what we're doing. There's a huge need to make discoveries in this area, and I think it's the combination of all the different things we do. We don't just do this one little specific kind of test. We do whatever it takes to solve the problem, which is basically to cure these chronic pain conditions and cure fatigue. And people respond to that. They want to be in a dynamic lab that is really 100% focused on changing the lives of people with these diseases. So it's a great response.
Great, yeah. So, okay. Now let's go on to the topic of today. Now, your lab does chronic pain and fatigue and neuroinflammation, and obviously it's possible or probable relationship to those two. Well, that covers many different conditions. But for the title of this question and answer session today, you decided we would discuss what is fibromyalgia and what is chronic fatigue syndrome. Now, the way you put those together kind of makes some people think that you may think they're both the same thing. So can you tell us, is that your theory?
My working hypothesis, where I'm starting from, is based on the symptomologic overlap. I am starting from the default hypothesis that they are probably different aspects of the same problem, which is probably an immune-driven problem. So I do think that brain inflammation is driving fibromyalgia and also driving ME/CFS, or chronic fatigue syndrome. But that is just a hypothesis, and as a scientist, I'm willing to put that aside or say that was wrong if the evidence says that it's just not true. Now, it's tough without having a blood test or some other test for either one of those. Really, no one knows the answer. Is fibromyalgia the same thing as chronic fatigue syndrome? There is a ton of overlap. Most people with fibromyalgia also meet criteria for chronic fatigue syndrome. Less so the other way, but it's still pretty significant. For me, we're going to start being able to answer that question this year, because one of our studies is going to be low-dose naltrexone for chronic fatigue syndrome. We already know it works well in fibromyalgia in our pilot trials. Now the question is, does it work equally well in chronic fatigue syndrome, or does it not? And either one of those are possible. So we're going to know pretty fast, starting within about a year, if those are the same thing, because if they are, a treatment that works for one should work for the other. If treatments for fibromyalgia don't work for fatigue, then they're probably different disorders.
So you already mentioned about the theory, Dr. Younger, about the neuroinflammation playing a strong role in both of those conditions. Now, the talk that you've talked about is the microglia. I'm sure we're going to get some questions about microglia. So you could give us just a quick summary of the microglia, at least what you found or you believe is happening in fibromyalgia and possibly being a factor in ME/CFS or chronic fatigue syndrome. And so give a quick summary of that,
Sure.
if you could, and then maybe how your research is going to be looking to answer that theory or find a resolution for that theory conclusively.
Yeah, I'll try to give a 30-second version so we can get to some other questions. Because people I do talk about this a lot in various kind of things that are online, but the basic story is, I think that a lot of chronic pain syndromes, chronic fatigue, cognitive issues, cases of depression and some other things, but we'll focus on pain and fatigue for right now. A lot of these problems are driven by inflammation in the central nervous system. Whenever you see symptoms that look a lot like when someone has the flu, which is it's hard to get motivation, you're tired all the time, you may be sensitive to pain, it's hard to concentrate. Those are kinds of things that you see when someone is sick, and we call that a sickness response. There's various terms for that, and that's caused by immune cells in the central nervous system that release pro-inflammatory agents that basically make you feel sick. They interact with different neurons in various regions of the brain, and they create all these symptoms. And they do that to make you go to bed and not do anything, which is a great idea if you have the flu. But if that system is constantly activated because something is broken, then you'll have those symptoms, but you're not actually sick. And so I think a lot of cases of pain and fatigue, the immune system has been hit, maybe by a virus, maybe by a bacteria, and it's been sensitized. So now it's reacting when it shouldn't. It's creating all these symptoms like you have a flu internally, but you don't actually have an infection. Now, maybe some people do have an infection, and that's a separate question. But I think a lot of cases, the thing has moved on, but their immune system is damaged, and it causes inflammation in the brain, and that causes these symptoms. So our job is to first see if that's the case, and that's extremely difficult to do because we're talking about the brains of living humans, and we can't get to it. So we've got to come up with really clever ways to measure the immune system without actually touching it, and that's not an easy thing. And then we have to create the best treatments for it. So it's about how do you diagnose it, how do you prove it's there, and then how do you treat it, and that's what we're all about.
Okay, so we're going to go on to the questions now. Although you chose a topic, we decided not to limit the questions to the particular topic. However, we've gotten a lot of response on the questions. Some were sent in ahead of time. So we know we're probably not going to be able to get to all of them, but we've got 40 minutes left to entertain a lot of these questions. So are you ready?
I'm ready.
Dr. Younger, you ready? Okay. Do you recommend low-dose naltrexone for ME/CFS now as you are doing the research to prove its effectiveness?
I can't recommend it right now, and I can't recommend anything until we've completed a clinical trial or someone else has completed a clinical trial. We are starting that exact trial within 2 months. I'm having meetings on Monday to finalize the setup. We're just going through the final regulatory processes at UAB, which is getting the IRB and the consent form straightened out. So it just takes a little bit of time to go through those steps, but we're going to do at minimum 10 individuals who perfectly meet the criteria for ME/CFS, and we are going to put them through a placebo-controlled trial this year. We will be finished this year as well, and at the end of that, we're going to have a good idea if low-dose naltrexone has an impact on ME/CFS. So more news coming soon. But in the meantime, I can't. Just because it helps fibromyalgia, that does not necessarily mean it's going to help ME/CFS.
Right. And you already did do a small study on fibromyalgia, though. So that's different than than this question concerning ME/CFS. And that goes back to the earlier question about whether they're the same. And you're studying to see if maybe one of the things you're doing is you're looking at the effect low-dose naltrexone has on ME/CFS to kind of answer that question, not necessarily if they're the same, but maybe if there's the same mechanism involved, right? Okay, good. We've got another question here. Is there a relationship between the brain temperature and the pain and fatigue that people have? I understand that's one of the things you're looking at, right?
Yes. Yeah, good question. We have acquired a new brain scan, and this is one of the projects that Dr. Jolyn is working on with me, where we can get brain temperature by putting someone in a MRI scanner, a normal MRI scanner, and it's a complex algorithm, but it actually gives us temperature throughout the brain. We just got this working maybe a month ago, so we've only run a handful of people, but we have run a small number of healthy individuals. We've run 2 individuals with chronic fatigue syndrome, and we've run 1 person with rheumatoid arthritis who also had a significant fatigue. And we have certainly found that the individuals with ME/CFS definitely had significantly higher brain temperature than the healthy controls, and it was about on par with the individual with rheumatoid arthritis. And rheumatoid arthritis is definitely an inflammatory condition. So the idea here is your brain temperature should normally be pretty close to your body temperature, like that 98.6 Fahrenheit, because your brain's hotter, but the blood circulates and it cools it off to get it close to body temperature. But we think when there's neuroinflammation, there's increased metabolic demand because there's all this immune stuff happening that requires more energy, so there's more heat created, and it overwhelms the circulating blood's ability to cool off the brain. And so that's going to manifest as an increase of brain temperature of maybe a degree, probably about 2 degrees Fahrenheit, close to 1 degree Celsius. And that may not sound like much, but in the brain, that's a huge deal because now you're pushing over 100 degrees Fahrenheit, and the brain is not supposed to fluctuate temperature. It's supposed to be very, very rigidly held in place. And so that's enough to create a lot of these symptoms we're talking about. So it's preliminary. Based on those preliminary results, we submitted a grant to NIH. We're going to hear back in probably 3 or 4 months, and I think they're going to like it. I think they're going to give us funding to do a much larger version of that. And if we find it in more people with fibromyalgia and chronic fatigue syndrome, we're going to have something really big because that's objective. It's brain temperature. And if we can show patients have it, controls don't, that's going to be really, really helpful.
Oh, wow. Wow, that's getting really high tech. I think I saw in the presentation you had, I didn't know when you were talking about brain temperatures that you could look at the different temperatures in different parts of the brain.
Yes.
That was wild.
Yeah, it's hard, but we can get kind of a map of the whole brain and look at if it's hotter in this area or not. That's trickier. So sometimes we average across the whole brain. That's easier to do. But yeah, we're certainly working on getting a complete 3D maps of the whole brain and its temperature from space to space.
Okay, then the next question we have, again, we're jumping all over the place on topics, folks, so just hold on. The next one is, are you going to pursue medical cannabis in your research?
Probably not. And it's interesting, and I think people need to do it, and there actually are groups that are doing it. It is very tough to do medical cannabis, cannabinoid research unless that's going to be your full-time thing, because it is so much work to get through the government regulatory hurdles and legal stuff. It's like a full-time job if you want to do cannabis research. So it's not the kind of thing you can do on the side or in addition to 10 other things. So because I see other groups, especially with fibromyalgia, so medical cannabis is being tested by multiple groups for pain. That's already covered. I don't need to do that. Now, I haven't seen anyone do it for ME/CFS, but that's going to come at some point. Although, to me, it makes more sense for chronic pain than chronic fatigue, but it should probably be looked at as well. But I'll leave that particular treatment approach to other researchers that are well beyond where I'm at with that anyway.
Okay, we have a question about the binder for the compounded LDN. I found a compounded pharmacy, but it says, what is the suggested binder? If somebody's going to use the low-dose naltrexone, it has to be compounded. What binder is recommended, or do you know? Is that more a question that should be asked to a pharmacist?
That is the best person to ask. And I do have some pharmacists who are really knowledgeable at that kind of thing, and I'm not sure exactly how that would answer that. For our clinical trials, all we put in those capsules, to my knowledge, was the naltrexone itself, the naltrexone hydrochloride, and we put a filler called Avicel, which I would consider it more of a filler than a binder, and it just kind of adds some space. And that was it. And we used gelatin capsules, and maybe some people should use a different type of capsule, but those really specific things, other pharmacies will say, no, you've got to use this filler or this binder, and they may be right, but it's really up to the pharmacist because they're the ones who can play around with a lot of different things, see how the patients respond, and then adjust. In research, it's really hard to do that. We have to decide what we're going to do, and we have to stick with it. So definitely look online, check some of the pharmacists, and actually I could check with our our pharmacist who knows this stuff really well, and that may be something I could post the answer to online or somehow get that out to people later.
So we
Okay.
had one question from somebody you know, John, who we met at the conference, who asked about the brain temperatures and whether that could be from blood flow as opposed to neuroinflammation.
Okay, yeah, absolutely. So that would be hypoperfusion, and that would be a case where there's inadequate blood flow, and that would also lead to increased brain temperature. Absolutely. What we're going to do, we need to make sure, and that could also actually lead to fatigue as well. So we have to control for that. We're going to do a scan, an arterial labeling scan. That basically what it does is it non-invasively tags blood as it moves through the neck, and then we can trace it as it goes through the brain, and we can see how fast it's distributed. That tells us whether someone has normal blood flow in the brain or abnormal blood flow. So everyone who does their temperature stuff is also going to get that perfusion scan, and that's going to tell us if it's slow blood flow, because if it's that will probably be the explanation for the temperature. So yeah, excellent, and we will definitely look at that with every person we study.
Great. Just a quick shout out to our international folks. We've got some now from the UK, and I appreciate everybody telling us where they're from. Got some Canada folks, and it looks like we've got 143 watching now.
Great, that's really awesome. I'm really appreciate everyone. This is our first one too, so I don't know how the word got out so well, but that's great.
The next question: will you be researching the connection between ME and central sleep apnea?
No, that's not going to be a topic that we're going to address specifically. So a lot of ME/CFS from a clinical perspective is dealing with all the other things that could cause fatigue and making sure you take care of that. Apnea being a great example. So if you're talking about apnea, you're either talking about, obstructive apnea, which is more common, and that's when there's something interfering with the airflow, or central, which is what you're talking about. If you suspect you have central sleep apnea, that's a pretty big deal, and that's something that has to be investigated independent of ME/CFS, because central sleep apnea means your brain is not sending adequate signals for you to breathe at night. That can mean there's a problem with your brainstem. It can mean you have a kidney disorder. It can mean some beginning of Alzheimer's and some neurodegenerative stuff. So not to be scary, but if you have suspected central sleep apnea, you should be being investigated clinically and treated for whatever problem is causing that. And it's possible when you resolve that apnea, your fatigue will get better, because if you're not sleeping through the night, of course you're going to be profoundly fatigued every day. And if you fix the apnea, you may feel better, and then we wouldn't consider that ME/CFS.
Okay.
So definitely, if you suspect apnea, if you hear that, get the sleep studies done. That is a really important thing to rule out. And then you have to address that apnea first before you start trying to treat ME/CFS as a separate entity.
Actually, Dr. Anthony Komarov gave a presentation at a hospital here in Birmingham, and he was asked that very question. What he said is that studies, or I don't know if it was studies or if he had discerned from his clinical practice, that there is a higher incidence of sleep apnea in ME/CFS, but the symptoms don't go away when the sleep apnea is treated.
Yeah, so you do the CPAP, which is the positive airflow, and if you're being treated and and it looks like your sleep is being improved, but you still have fatigue, then yeah, it's possible you have both at the same time, and then we talk about kind of treating the ME/CFS. So that's definitely possible.
Okay, we have a question from Dyspnea. You know what? I better not be guessing on some of these names. Will you be exploring transcranial direct stimulation for fibromyalgia? It was released in Europe as a treatment. You know what she's talking about?
I do. So there are a couple. There's direct current stimulation, and then there's transcranial magnetic stimulation, which is actually a kind of more hardcore version of it, and more expensive as well. The one that person's talking about is actually a pretty inexpensive piece of equipment that can pass currents right underneath the skull, and so you can change neuronal firing, and it's being tested for depression and for pain and can help with fatigue. Absolutely, it's an interesting modality, and then transcranial magnetic stimulation uses these coils, and it can really change your brain activity. They're powerful techniques. I probably will not be looking at those because, again, there are other groups. I actually have several colleagues that are using those things for pain and maybe fatigue and also depression. So I think that's being adequately covered. Researchers are certainly aware that it's a potential treatment. It's being trialed for many, many different things.
So do you believe CFS overlaps with elements of Gulf War illness, such as the neuroinflammation, the mitochondrial damage? And so do you believe your research may have an impact on discovering or the cause or the mechanisms of Gulf War illness, or possibly developing treatments for it?
Yeah, so again, just like fibromyalgia and ME/CFS, I do pull Gulf War illness into that just based on the symptoms and also based on the disease seems to have started when they were deployed to the Persian Gulf and they got a large number of immunizations that would slam the immune system. So as far as how it might start, it fits with their hypothesis of fibromyalgia and chronic fatigue syndrome. So I am working from the position that they are the same unless the data tell me that they're different. And we're doing those studies. So again, anything that works in fibromyalgia, we're going to test it in Gulf War illness as well, and vice versa. So we have a trial right now to try 9 different botanicals in Gulf War illness, and the Department of Defense funded us to do that. Things like curcumin, reishi mushroom, stinging nettle. These are old botanicals that have excellent anti-inflammatory properties. So we're going to test them in Gulf War illness first because it's what we were funded to do. But if we find 2 or 3 of those that just, knock GWI out of the park, of course, the next thing I'm going to do, I'm going to try it in ME/CFS, I'm going to try it in fibromyalgia, and then we'll find out soon enough, I guess, if those are the same disorders or not.
And one of the reasons you went after Gulf War illness first, even though that's not been your primary, is probably because of the funding you were able to get from the Department of Defense, right?
Yeah, that's true. That's part of it. I mean, you can't do research in an area if you don't have funding for it. So all agencies, NIH, DOD, other agencies, they make funding opportunities for the things that are priorities for them. And that certainly does, to some extent, change what researchers focus on. I was very comfortable going after GWI because conceptually, to me, it's essentially the same disorder. That's my working hypothesis. It may be wrong. So I thought by researching that, I'm still making advances in fibromyalgia or chronic fatigue syndrome. So it's still in line with what I really want to do. And I'm really glad that there's funding available to do that because that's a group that, it's a similar story. They're not believed. They've gone 20 plus years of not being taken seriously, and we need to figure it out and treat it.
Okay, well, following the theme of other illnesses connected to or that has been associated with ME/CFS or fibromyalgia, we've had a couple of questions where someone asked, what do you believe are the overlaps between ME/CFS and fibromyalgia and Lyme disease? And then also, someone said their concern is that actually these ME/CFS people and fibromyalgia people have not been diagnosed with the Lyme disease that they actually do have, according to what many people think. And I guess following those lines, you're not studying Lyme disease patients now, but how could your research have an impact on patients that have Lyme disease or continue to have symptoms even after they've received the short dose antibiotic treatment that is commonly recommended?
There's a few different directions. If someone was exposed to a tick and they may have been introduced to Borrelia or another bacteria, so they may have an active infection, in which case they have measurable titers of that bacteria and also antibodies. If that is the case, it is essential that that infection is treated as an infection. That's not fibromyalgia, it's not ME/CFS, that's an infection that needs to be eradicated because if that goes on too long, it will damage the immune system and cause sustained problems. So that's one thing. So absolutely, number one, not enough people get tested for the Borrelia bacteria, and a lot of the tests aren't that good. Some people will only test the bacteria and they won't test the antibodies, so you don't know if you had it previously. And it gets even worse because we're discovering all the time other strains of bacteria that are carried by ticks that cause Lyme and similar disorders, but they're not going to be picked up by that classic Lyme disease test. So yes, a lot of people with fibromyalgia or ME/CFS may have a active bacterial infection. Now, a lot of those people, if that's the case, you'll have elevated body temperature. So especially if you have a fever that doesn't go away, then especially focus on that infection angle. However, there's another possibility, and that is you had the infection, but now it's gone, but it left its mark on your immune system, which is kind of what I was talking about at the beginning. So I think a lot of people, when we say they have Lyme disease, they might have had that bacteria, but now they have something that, I don't know what the official term would be, but I would call it like post-Lyme syndrome, which is basically all the symptoms of Lyme, but the infection is gone, and that's because the immune system has been damaged. And then we would treat it more like fibromyalgia or ME/CFS, because I think that's more a problem of a dysregulated immune system. But we need to get the tests done more often. Of course, if you had a tick or, then it's essential to get those tests. And again, I don't like to talk about particular companies, but now people are catching on, and there are companies available that do very comprehensive screenings for multiple bacteria. It's a good idea. It's just so expensive that I wish in my research I could test everyone for everything before they get into the studies, because I know we're missing stuff. It's just you'd have to do $100,000 worth of tests on everyone to rule out all the possibilities, but it's certainly something to think about. I think it would describe quite a few cases of fibromyalgia and ME/CFS.
Okay, and we have a question from my friend and someone that a lot of people in our communities, both fibromyalgia and ME/CFS, knows. Court Johnson asked, how is it going on your neuroinflammation study? How long do you expect before you'll get results? And Court, I'm sorry, I don't know which neuroinflammation study. I think he's doing a lot of them. So why don't you tell us what neuroinflammation studies you're doing, and then how's it going, and when should we see results?
Yeah, that is true. I don't know exactly which one we're referring to. I have to keep a board with all my studies listed on it, because if I can probably think of about a third at any given time. So let me tell you what's going on in this year. Well, actually, it's stuff we're starting. So I tell you what, maybe which one's more interesting? Maybe I can say that afterwards. So first, let me tell you what's going on right now and what the progress is. The brain temperature stuff, very small so far, but it's looking very promising. The study where we track people over time and then we test for inflammatory things in the blood, which we've already published that once, and now the NIH gave us a lot of money to do it on 200 plus people. We just finished another cohort of that, which was incredible. I sent a note about that in the newsletter, because we got 13 people through 25 days of daily blood draws, which is amazing. Especially since at UAB there was a car fire in the parking lot for the hospital, and it pretty much closed the whole thing down. So our team, again, this is Kate Sides, and she has a large crew of mostly undergraduates who are helping with this. They just did an incredible job, and the participants did an incredible job finding alternative ways to get to the place where we're doing the blood draws every day, and that is so much to ask. And so I'm really grateful that everyone pulled together and got that done, because we have amazing data from it. So anyway, the studies are going really well. We've got a really good recruitment engine going, so we're getting people in, we're running people very fast. So no new results to talk about, but probably in 3 months or so we'll start having new stuff that we can discuss.
Okay. No, I think Court Johnson, he just typed in, he told me he was talking about the brain temperature stuff.
Okay, yeah, again, that's, we're trying it in a lot of different disorders. So we're trying it in fibromyalgia, chronic fatigue. So if you have chronic fatigue syndrome or fibromyalgia, we will be recruiting this year, and not very long, we'll be recruiting for brain temperature studies. And all you have to do is come in for less than 2 hours. We don't inject anything. It doesn't hurt. You just lay in the scanner. You can go to sleep if you want. We'll scan your temperature, and we will compare it to other groups. So we're going to do fibromyalgia, chronic fatigue syndrome. We're probably going to do multiple sclerosis, and we're going to do traumatic brain injury as well, because when you have a brain injury, you have damaged tissue, but then you have inflammation around that. So we want to look at different disorders. So I think it's going very well. We're still perfecting the technique, but so far so good.
Someone ask that you did a call out to do that on, I think that was the one you were doing on rheumatoid arthritis patients, weren't you?
Yeah, I'm sorry, I forgot that one. That wasn't a full study. So basically, we did that really fast. And so I think we had 3 individuals with rheumatoid arthritis, mostly to generate data to get a grant. So we submitted a grant to do a larger study just on rheumatoid arthritis. And the pilot individuals, the first individual showed we had elevated brain temperature in RA, just as we hypothesized. So we put that in the grant. That went to a rheumatologic foundation, and we should hear within the next month if we have that funded or not. So we may have another study in RA with brain temperature.
Okay, so you'll be making an announcement, I'm sure, when you're
Yep.
ready for people to come in who have the other diseases to get their temperature, their brain temperature. We got hotheads, right? Is that right? Hotheads?
Yeah, I can't wait for the news media reports on these if it turns out to be the case. Yeah, but we will certainly, every time we start a new study, it's going to be easy to hear about. We're going to put out in the newsletter if you're on a listserv. We'll put it on Facebook if you're following that. And probably I'll do a little short video anytime I'm starting a new study, and we'll put it on the YouTube channel as well. So there'll be
Okay.
multiple ways you'll hear about it.
Okay, good. So if somebody's taking low-dose naltrexone, would they still be eligible for some of your studies? Some people have found such good results, they don't want to go off of it, but they want to help you in your research.
The LDN would preclude someone from most of the studies. For reasons people can probably guess, if we think you're receiving a treatment that actually fixes the problem, then it may be hard to see that problem in you, because it may reduce the blood test or wherever we're looking at. So truthfully, it would prevent from a lot of studies. However, there are exceptions. And so we may still do the brain temperature in someone with low-dose naltrexone. And some of the clinical trials, actually, we have one coming up pretty soon with dextromethorphan. And one of the things I'm curious to see is if dextromethorphan works better when it's combined with LDN. So someone already on LDN, we'll just add the dextromethorphan and see what the response is. So there are possibilities.
Okay.
But it's a smaller number of studies if you want to stay on LDN.
So again, they'll just need to stay plugged in, stay connected to what you're doing. We've had 2 questions that have to do with the alcohol sensitivity study. Is that something you're doing? And has it already started? And have you gotten any
Oh, yeah.
preliminary findings?
So Dr. Luke Parketney is leading that study, and it's pretty small. It's a lot of the stuff we do are pilot studies, and we see what works, and then we write a grant to do a bigger version. So this is still the pilot stage. We need 2 more people. And actually 2 more healthy controls. So we've run the fibromyalgia group, and the idea behind this is when I'm running these low-dose naltrexone studies, I kept bringing in people and we'd screen them, and no one was drinking alcohol. And same thing with ME/CFS, and they're like, I just don't like it. I don't feel good. And it just happened way more than by chance. And so we thought that maybe the alcohol is perturbing the immune system and actually aggravating the fibromyalgia or chronic fatigue symptoms. So we're testing the immune system response to alcohol. So we've finished fibromyalgia. We need 2 healthy individuals. Now that's at the time of, this is March 3rd, right? So if you're looking at it live, as of right now, we need 2 people, and I think we'll have it done in 2 weeks.
Okay.
Then it'll take a month and a half to get the assays run on the blood, the results back, and we'll do the statistics. So I would say, within 3 months, we'll know a tentative answer to the question, does alcohol actually do something strange to individuals particularly with fibromyalgia?
Did you have any trouble in Birmingham finding some patients that were willing to?
I think it was harder to recruit for that study than other studies we do. But think about it. We're saying, you basically have a little bit of vodka and you get paid $300 and you get to lay around all day. I don't think it's a bad deal. But it was a little difficult to recruit. But now we're right there, almost finished. So we're good.
Okay, good. How about Rituxan? Now we've seen that Rituxan has had a positive spot. I think that in some ME/CFS patients, and we had somebody who asked about Copaxone, which is another B cell modulator. It's commonly described for MS. So the person is asking based on their experience with Copaxone, do you see that maybe it could have a positive effect similar to what Rituxan
Yeah, very possible. Again, as you can tell, I think that these diseases are abnormal inflammatory diseases, and just like multiple sclerosis is, I think the difference between MS and multiple sclerosis and chronic fatigue syndrome, fibromyalgia, is multiple sclerosis is inflammation plus neural damage, where the white matter of the neurons have actually been eaten away, and that keeps the neurons from functioning properly, which is not the case with fibromyalgia or any CFS. So I think MS is a more extreme version, but I think they still have that root cause of inflammation in the central nervous system. It's just a matter of degree. So the idea behind these drugs that you're talking about is to deplete the B cell population, which keeps those cells from breaking through the blood-brain barrier and assaulting the central nervous system. So if you have fewer B cells, you have fewer cells that can go in and cause a problem in the brain. If I were looking at those types of drugs, I would hypothesize that it would help a lot of individuals. Now, of course, you're wiping out your B cell population, so there are serious considerations and adverse events you have to talk with your physician, but I think it is a potentially promising line of clinical research.
Okay. I've got one more question to ask, but before I ask it, we've got let me ask this. I've got two more questions then. Once a biomarker is established, how long before a test would be available? How long after that could we expect a treatment option?
Okay, so if someone came up with a valid, repeatable, accurate blood test for ME/CFS or for fibromyalgia or for both, it would catalyze the field enormously. I mean, it would speed things up super fast, because once you know what to focus on, there are groups that can create new drugs really fast. So, so if they found something, it would be turned into a commercial diagnostic test pretty quickly. Maybe not as fast as a year, because government stuff slows it down, but definitely within 2 years. That's assuming it works. So that part would be fast. Now, to turn that into a treatment, that's longer, but it could be done, best case would be 5 years, just because there's so many steps involved,
Right.
that it's built to be a slow process. So it would take a while, but that's why I really think we need to focus on clinical trials on things that people can take right now, because we don't want to wait for a new drug to be developed and have to go through mice and other rodents and then go through all this stuff. We want stuff that works right now, and there are literally dozens of things that could potentially help. And we just need to get the funding and the infrastructure to run those trials, and we may have a treatment already.
That kind of segues into the question we've had a couple of people ask about the announcement from the Australian group that came out with some immune system or genetic test that they think is going to become a marker for ME/CFS. Have you seen that?
This is Marshall
Yes.
Gratznik.
Yeah.
So, that's so new that it's hard to know exactly what they're doing, but I did see her 2016 paper, and it is immune-based to my knowledge. Now, maybe, there was this recent thing, and it seems they're saying, we've got the test, we've figured it out. So I don't know if that's exactly what the 2016 paper was, or if they've added stuff to it, but based on the information I have, it's an immune test, and I think they were looking at T cells that have learned to attack things in the body, and they found an abnormal number of receptors on those T cells. I think it was IL-7, interleukin 7. So basically, the short story is they found evidence of dysregulated immune cells in ME/CFS, different from what they see in multiple sclerosis. So it distinguished between CFS and controls and between CFS and MS. And for it to be a good test, you have to be able to determine what disease you have by the test. So if the piece is true, the media report, because there was a lot of hype in it, and it was like, we figured it out. I hope it's the case. As a scientist, I'm always skeptical. We have to be. And so we have to see more data. We have to see validation. But I will say that this researcher has been doing this stuff for a while and has a lot of really good publications. So I'm optimistic. And also what they were working on are the same type of things, maybe even more detailed than what I do. So I certainly believe in the general hypothesis. So yeah, there may be something really interesting there, and we'll just have to get more information. But
Okay.
yeah, I'll be following it very closely.
That reminds me of the study that was released a few years ago that I just thought was great, and it was looking at the proteins in the cerebral spinal fluid of ME/CFS patients compared to what they termed post-treatment Lyme disease neurological something,
Yeah.
and healthy people, and they said the proteins were different in those three groups, and some were the same, but there were some overlap on all of them, but there were some that were that could distinguish those three groups.
So that's part of when it goes back to how hard it is to look at brain inflammation, which is where we need to be looking. But if everyone was born with these ports in their head, and we could just go in there and sample brain fluid, we'd already have these things figured out, I'm sure. Our problem is purely because we can't get to the place where the problem is, and so we try to find substitutes. So a lot of people draw peripheral blood, including us, but that's a really poor substitute for what's going on in the brain. It's not the same thing, and the systems are isolated. So people try to do lumbar punctures to get cerebral spinal fluid because that's kind of like the brain fluid, but even that's not perfect. In fact, it may not be a good representation because there's gradients to these things, and the further away you get from the brain, the less representative what you find is of the brain. So it's very interesting. We'd love to get that stuff from the brain. We just can't figure out how to do it yet. We're working on it.
Okay, I just thought that was going to possibly lead to a test, but I followed up with one of the members of that research, and he said, well, we needed more funding. We didn't get any more. Come to the end. We're going to go a little bit over, so
Okay.
just real quick, could you give us any closing remarks? I've got one more question to ask, but before I ask that, I want to give you an opportunity to give us any closing remarks or anything the take-home message that you want people to know about your work at the lab at UAB, or what your understanding of the diseases are.
There's so many directions I could go with that. I will say first, so I do have something that I'd like to talk about, but in terms of the questions, because I'm sure we didn't get through, I don't know, did we get through half, quarter? Anyway, I will answer all these questions, and so I guess we're going to probably do this once a month until we get caught up, and then we'll go from there. So we'll try to do these very frequently, and also I'm going to do some videos, not Q&A sessions, but separate from that, videos where I'm just by myself explaining the project. So the idea is we want to get information out about everything we're doing and answer these questions that people have. So so don't worry if your question didn't get answered.
Yeah.
We will get to it. And these will all be recorded so you can visit them later. Okay. Again, a lot of things we could talk about. I do want to get people thinking about something because it's one of my biggest projects for 2016. You heard me mention a couple times that it's really slow to do clinical trials and to get results out. And I think patients are getting really frustrated because just how slow the science is going. And part of that is because the funding is so difficult to get and it takes so long. It can take 2 years to get funding for a clinical trial. And it's so hard to get the money that researchers have to focus on one or two things. And so they end up, there's all these things that never get tested. I mean, like I said, there's dozens of things that we should try, but we just can't get the resources to do it. And doing it through NIH just takes too long. So what you're going to see me working on this year is to start a fast-track clinical trial center. And that is a center that is purely designed to do nothing but run clinical trials on pain and fatigue and related disorders as quickly as possible. And we're planning on running dozen plus at a time. So the idea is we're constantly putting out the results of clinical trials, getting it out there so people get the information about what treatments may be promising. So that's going to be a very ambitious thing. It's going to take probably $4 million to get that thing started in a really healthy form. But if we get that, we will be able to so much more rapidly test these potential treatments. And then we'll be able to get it self-sustaining after that point. So you're going to hear me talk about that. I'll probably do a video about that, and there'll probably be a media story coming out pretty soon about that as well. But I think I've become frustrated at how slow it is. That's not a knock on NIH. They make United States the best place to do science. But in addition to that, we have to have a faster way to do all these trials. And it's going to take a different type of system to do that. So I will be putting a lot of effort into making that happen. So just to plant that seed in people's minds so you're thinking about that. And I think that's the way to make the biggest impact the fastest. So looking forward to figuring out how to do that.
Okay, my final question is, what do you think is most lacking that could move this type of research forward? Is it awareness in and out of the medical community? Is it the political will? Is it funding? Is it advocates who are able to do it, getting more active? Do we need lobbyists, or is it a combination of all of it? What is it that needs, where do we go? What needs to happen to make the progress in your research? Or in this research in general?
Yeah, everything you mentioned is something that could use more effort behind it. From myself as a researcher, it comes down to the funding primarily. Now, one thing I ask is from people who have these disorders that all these studies that do clinical trials, we need participants in the studies. And so if we can't have people participate, the studies don't go anywhere. And recruitment is generally very hard for most trials because people are scared of clinical trials. You know, what are they going to do to me? I don't want to be used as a guinea pig. So, you know, pick and choose. But if there's a research project you think you could feel comfortable doing, check it out and participate. Do the screening, participate if you can. The part I'm mostly concerned about is the funding, which kind of goes back to that Fast Track Center. We need to be able to get funding to make something that works faster and better. So I'll be trying to find ways to do that, and that may be private foundations, that could be a rich benefactor, that may be a crowdfunding thing. So we'll try to find the best way to do that, but it's a big target. So the funding is important. People who have the ability to put pressure on government entities, state level, federal level, to get more congressional support by an NIH and ME/CFS, all that stuff is helpful. So I actually am pretty encouraged by all the discussion groups I see and groups that promote low-dose naltrexone, that are trying to get things changed. And I just encourage people to do more of that. I know the discussions get hairy at times because there's a lot of controversy in these disorders, and some things come out that are hugely controversial. And so, but still, that discussion is very helpful. And I think eventually, get enough people on board. The clinicians, I think they're going to be, a lot of them will be initially resistant, but I see everywhere I go, more and more are getting on board with this idea. They just need something, they need a test, they need a treatment that actually works, and then there's not going to be a problem anymore. So I think let's really focus on the research. Let's get that stuff done, and then provide the physicians and clinicians with the tools they need, and that's how we're going to knock this out as soon as possible.
Okay, great. And I want to apologize for everyone. We were not able to get to everybody's question. But I appreciate that Dr. Younger is going to be doing these presentations. So I've got some closing things I need to say. So we're going to say goodbye to you, Dr. Younger.
Okay.
Okay, and we will then, wait to hear the announcement of when the next presentation, and we're going to urge everybody to stay connected. You can stay informed by joining the Younger Lab Facebook. You see I've got a bit.ly here, so you can use that bit.ly to go to it, or you can just do a search in Facebook. It's the Neuroinflammation, Pain, and Fatigue Lab. You can also sign up for the newsletter, and that is through the bit.ly that I've also provided down there. So follow that bit.ly. I think you have to use the capitals the way I've got it there. And of course, for the next question and answer session, or for the next videos or any other announcements, it'll be released through the newsletter. Also, you can subscribe to this YouTube channel. It is the Younger Lab channel, and you see there's a subscribe, a way to subscribe. We've already got at least 15 that have subscribed even before our session began today. You can also reach me if you go to tina@tidcom.net. I have my own email notification list, and you can contact me that way. So thank you, everybody, for participating, for watching. We had about 141 at the peak, and that is just a great turnout, and it motivated Dr. Younger to do these more often. So thank you, and have a good evening.